Welcome to the 2023 Lupus Ontario Virtual Symposium. This year's theme is Care for All. Care for those in need of medical attention and intervention, but care for the caregiver too, physicians and family members alike. Today, the word care serves as an acronym to guide our time together. Community, ensuring equitable care, treatment, and diagnosis, regardless of ethnicity and culture. Access, regarding challenges seeking care, but also when it comes to treatment options. Resources, what are some of the resources and tools available to help further the care needs of patients while also building expertise among physicians? And education, when it comes to cutting-edge research that might even be able to identify or perhaps one day predict when a flare may occur for someone living with lupus. Each of our renowned presenters today will be speaking to at least one of these topics, as well as covering much more. Before moving to our first speaker today, I would like to take a moment and remember one of the founders and driving force behind Lupus Ontario. Many of you knew, or certainly knew of, Honey Agar, who passed away on September 30th. Diagnosed with lupus in 1970 and hospitalized in 1978, Honey and her hospital roommate, also a lupus patient, set out to create awareness in communities, families, patients, and physicians on lupus. In 1978, the Ontario Lupus Association was born. The OLA, as it was known, would eventually become the Lupus Ontario we all know today, and even play a role in the creation of Lupus Canada. Honey was our first president, setting the goal we continue to work toward of life without lupus. Honey Agar turned her life with lupus into hope for countless people. Her efforts helped to raise millions in support of this cause, the establishing of lupus clinics across the province, the creation of a world-first lupus data bank at Toronto Western Hospital, and the endowment of the Jeff Carr Fellowship, and so much more. As we move through the presentations today, think of Honey's impact. And despite the challenges that remain for those living with lupus, think of how much has been accomplished since 1970 and moving toward truly living a life without lupus. And so with that said, I will now introduce our first speaker for today. And I should just circle back as well and say, my name is Brent Leonard and I'm a member of the board with Lupus Ontario. Our first session this morning is with Dr. Teresa Semalulu and touches on the topic of community, exploring racial disparities in Canadian healthcare. Dr. Semalulu is a clinical and research fellow at the Toronto Western Lupus Clinic. She completed her internal medicine and rheumatology training at McMaster University and her medical school studies at the Northern Ontario School of Medicine, or NOSM. Her academic interests include systemic lupus erythematosus, best practices for the transition of patients from pediatric to adult rheumatology, health disparities, and global health. Dr. Semalulu is this year's Jeff Carr Fellowship recipient, with an aim to explore racial disparities in disease related to disease activity and damage in SLE. During the tenure of her fellowship, she is pursuing a Master of Science in Clinical Epidemiology through the Institute of Health Policy, Management, and Evaluation and Training in the Clinical Investigator Program at U of T. At the end of the presentation, we will have a Q&A session, so please do use the chat or Q&A features that you see before you to submit your questions, and we'll be sure to get to them at the end of the presentation. Dr. Semalulu, thank you so much for joining us this morning, and I will turn our virtual stage over to you for your presentation. Since I've lost my unsharing capabilities, it seems, feel free to share over top of mine or disconnect me somehow.
No problem. All right, thank you so much for that introduction. I will get started. So yes, I'm Dr. Semalulu. I'm a clinical fellow at the Toronto Western Lupus Clinic and the recipient of the Jeff Carr Fellowship. The name of my presentation is SLE, Exploring Racial Disparities in the Canadian Context. So I have no disclosures to make. So I have three objectives for this presentation. The first one is to define health disparities, race, and ethnicity. The second one is to review racial and ethnic disparities in adult patients with lupus. And the third one is to discuss what is known about racial disparities in lupus in the Canadian context and future directions. So just to give a little bit of background, as all of us know, lupus is a complex, multi-systemic autoimmune disease that has the ability to impact multiple organs. It is heterogeneous in nature, meaning its presentation has a wide variation. It can range from very mild disease like rashes and joint pains to very severe disease, leading to involvement of the kidneys, the brain, or even the heart. The prevalence in Canada, you'll see different numbers, but I'll just quote here about 32 to 51 per 100,000 population. So although it's rare, it's not uncommon. We see it quite often in rheumatology in general. And then, of course, we have a whole clinic at the Toronto Western Hospital. So before we delve into some of the research, I just wanted to make sure that we all have an understanding of what health disparities are and some additional definitions. So health disparities can be defined as preventable differences in the burden of disease or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. So essentially what we're talking about are differences in health status between different groups. This figure on the right shows that there are numerous causes or potential causes for health disparities in lupus and overlaps with other diseases. But in lupus, we see disparities related to things like gender, research, healthcare systems, education, patient and physician factors. And of course, we're going to be talking about disparities related to race and ethnicity today. But just keep in mind that none of these act in isolation. Multiple factors can be acting sort of together. So we always have to think about more than one potential underlying cause for some of the disparities that we're seeing. So I like this diagram here on the right side of the screen because it really differentiates gives you an idea of the difference between equality and equity. And really what we're trying to achieve when we're addressing health disparities is equity. So equality essentially means everybody is treated the same, regardless of their resources. We all give them just one stool, and they're supposed to achieve the same health outcomes as everybody else. Equity, however, recognizes that everybody has different needs and may require different resources. So the objective in order to obtain equity is to ensure that everybody has the resources that they need to achieve optimal health. So really what we're trying to address is inequity, which is defined as disparities that arise from differences in social, economic, environmental, and healthcare resources. That's what we're going to target so we can reduce health disparities. So this diagram here, it's a little bit complex. I won't go too much into detail, but it just highlights that in order to address health disparities, we really need to be addressing factors outside of the individual, as well as factors related to the individual. So we need to be addressing social factors, political factors, structural factors, community factors, as well as modifiable factors related to the person's health. Non-modifiable factors, including age, race, and sex are non-modifiable. So we have to just keep that in mind when we're looking at health disparities, that we can address all the issues around those non-modifiable factors. So again, more definitions to go through. So what is race? I think we take it for granted what race truly is. Even throughout my medical training, we talked a lot about race, but we never actually delved into what it actually is. And race is a social construct, meaning there's no biologic race. We can't take a blood test and determine someone's race. It's really defined by society. And it's actually quite interesting because it's only really recent that the medical literature has come up to date and really highlighted that race and ethnicity are social constructs, and they do not have scientific or biologic meaning. This paper here that I'm highlighting is from one of our most prestigious medical journals, the Journal of American Medical Association. And as you can see, it's only in 2021 that they were really put their foot down to highlight that these are social constructs. They say that races should be referred to as broad categories of people that are divided relatively arbitrarily, but based on their ancestral origin and physical characteristics, so nothing to do with their biology or nothing directly. And ethnicity should be referred to as a person's cultural identity. So more their language, their customs, and their religion. So you can see how there's an overlap, but the main thing to highlight is there's no biologic basis to both of these terms, and that these are social definitions. However, just because there's no biologic basis to these terms, it doesn't mean that they're not important. If we do ignore race and ethnicity, because there's no biologic basis, then we're going to be ignoring the impact of these concepts on causing injustices and inequities. So it is important to use race and ethnicity in research, and I will highlight why that is today. Two other definitions I'd just like to go through before we get into things a bit further are ancestry and genetic admixture. And I think this is what we think about when we're actually using race and ethnicity in the context of medical literature, but we just haven't yet come to use these terms. So the term ancestry refers to a person's country or region of origin or an individual's lineage of descent, while the term genetic admixture refers to genetic exchange among people of different ancestries, and it might correlate with an individual's risk for certain genetic diseases. So when we're trying to actually assess someone's risk, we should be looking at these things, their genetic ancestry, their genetic admixture, to get an idea of what their actual risk might be. And this just highlights it there, that ancestry and genetic mixture might provide more useful information when we're assessing for things like genetic variants or risk of disease. Although race and ethnicity are kind of proxies or kind of representatives of these two terms, they're not perfect. So race and ethnicity and lupus, what do we know about it? So lupus disproportionately impacts racial and ethnic minorities. It's 2 to 3 times more prevalent among racialized people. And in general, racialized patients and ethnic minorities have poor outcomes in lupus. This diagram here, I really like it because when we're examining racial disparities and we're making conclusions about the impact of race on disease outcomes, we just have to keep in mind that race does not equal genetics. So we should never conclude that, the outcomes or disparities are a direct consequence of someone's genetics. We have to understand that race is reflective of a combination of things. So this diagram shows that race is sort of reflective or representative of an interplay between genetic factors, like we just chatted about, and non-genetic factors like environmental factors, societal factors, behavioral factors. And that's really what we're looking at when we look at race and ethnicity. So racial disparities, what do we know? We actually know quite a bit, and this is an abstract or a poster of some work that I did with Dr. Celios, who's speaking later today, and we'll be publishing soon. It's a systematic review of racial and ethnic disparities and disease-related outcomes among patients with lupus. So I will go through this. I'm not going to go through it in the most detail, but it'll give you an idea of what is out there in the literature. What do we know about racial and ethnic disparities in lupus? So the objective of this systematic review was to describe racial and ethnic disparities in the following disease-related outcomes among patients with lupus. So really what we were looking at was mortality or death, end-stage renal disease, so kidney disease at the end stage requiring dialysis, disease-related damage, cardiovascular disease, so there we're talking about heart attacks and stroke, malignancies, so cancers, and then hospital utilization, so things like hospital admission rates. And we did a systematic review of the literature, which is a deep dive into literature to try to identify all the articles that are relevant. We searched 3 of the major medical databases, and in order to search it, we used terms to describe the outcomes of interest, and then also variations of terms used to describe different racial and ethnic groups. And one thing I forgot to mention prior was that because race is a social construct, it's not static, and you'll see different racial and ethnic groups terms used in different parts of the world, and that's reflected in the literature that we'll review today. So really, I'm just going to use the same term that was used in each article, but usually there is some overlap. In terms of the methods, again, I won't go into great detail, but the articles that we selected from this review were ones that included lupus patients, our outcomes of interest, and that followed patients over time, at least 2 years. So we had lots of results. We ended up initially with 8,500 results. There were a lot of duplicates or doubles, so we removed those. Once we removed those, we reviewed about 5,528 titles and abstracts, just kind of an initial screening to see if we think the articles are relevant. And then we reviewed the full articles, 191 of them, and we found that 127 addressed our question. So here's a high-level overview of our results. So first, the locations of the studies, not really surprising. Most of them were in North America. Really, most of them were in the United States. Other places that had many studies would be Europe and Australia, Africa, Asia. Very few in those other places of the world. Racial and ethnic groups identified. So Blacks were most commonly identified, followed by whites, Asians, and Hispanics. A few studies did identify Indigenous peoples and other groups. This table here is a very, very high-level summary of all of the studies. So I'll just highlight a few things. Most of the studies looked at mortality, end-stage renal disease, and disease-related damage. And what you can see that most of the studies, so here just on right, I think you can see my arrow, most of the studies reported worse outcomes in racial and ethnic minorities to some capacity. So I can't go through 127 studies. So what I did is I selected studies in each of these categories that had a large number of patients and that I think were quite reflective of what we saw overall. So I'll summarize those for you. In terms of mortality, we have this study that was done in the United States with using national vital statistics from 1988 to 2017. You can see that they had 10,793 Black patients and almost 20,000 white women who had died with lupus. And what they found was that among all age groups of the patients included in the study, Black patients were almost 4 times more likely to die. And so this diagram just kind of shows that in numbers. You can see that the Black patients compared to white patients had 4 times higher mortality rate when you looked at all ages of lupus patients. And actually, when you looked at patients aged 25 to 44, Black patients had 5 to 7 times higher likelihood of dying compared to white patients. So quite substantial. So that only looked at 2 racial groups. There was another study done in the United States over the course of 10 years. This one was extremely large. There was 2,000 patients with lupus that were included. And what they found was that Asian or Pacific Islander race had the highest risk of death compared to white patients. So that was mortality. The next thing we'll discuss is end-stage renal disease or kidney disease resulting in dialysis. And so what you can see overall is what they found looking at cases of end-stage renal disease from 1982 to 1995 is that overall there was a trend upwards of the need for end-stage renal disease in patients with lupus nephritis. But what I will highlight here in red is that, as you can see, the cases were much higher in Black patients compared to the other 2 groups, Asian, Pacific Islanders, and white patients. And they did take into account, they wondered, is this just because there's more lupus nephritis in these patients, or is it because the patients are surviving longer? And they did some fancy statistics and they realized that that wasn't the case. What they did postulate was that perhaps a certain subset of patients are not receiving maybe the standard of care because there were some new medications that came out throughout that period of time, and perhaps that's accounting for that rate. However, they weren't able to actually prove that in that study. The next study I think is quite interesting. And the reason I selected this one is because it really highlights how ethnicity serves as a proxy or a representative for genetic ancestry. So again, I put this picture here again. We're talking about ethnicity serving as a representative for genetic ancestry. And they were actually able to highlight that in this study. So I'll go through it in quite a bit of detail. And so the study was the LUMINA study, the Lupus in Minorities, Nature versus Nurture study. And basically this study was established to determine factors that predicted various outcomes among lupus patients. And so they included 4 ethnic groups. So Hispanic patients from Texas, they were primarily Mexican and Central American ancestry, Hispanic people from Puerto Rico, African Americans, and Caucasians. And the geographic locations were Texas, Alabama, and Puerto Rico, and there was 3 academic institutions involved. So basically what they wanted to do, like I had said previously, is examine the extent to which admixture and social factors account for ethnic disparities observed in the observance of renal involvement. And so I'll go through this table on the left here. What they did is to assess ancestry, they actually did some blood tests, the ancestry informative markers, to assess someone's genetics to determine their actual genetic ancestry. And so you can see that there on the left. And then the box, the upper row, ethnic groups. These were self-reported ethnic groups, but they really wanted things to be as consistent as possible, like a well-defined ethnic group. So in order to identify in one of those ethnic groups, all 4 of that person's grandparents had to be the same ethnic group. So essentially they were trying to get the most pure, I guess, person that has self-reported that ethnic group, and then tried to determine their genetic ancestry based off that. And even though they went to the grandparents, what you'll see is that Hispanics from Texas were found to have, some mixture, but a large component of Amerindian genetic background, and that term that they use, they're referring to indigenous population. Puerto Rican participants, they did have a high percentage of Amerindian ancestry, but they had more equal percentages of African ancestry and Caucasian or European ancestry. And then African Americans had a large percentage of African ancestry, and Caucasians had a large percentage of Caucasian or European ancestry. So that's what the population looked like. Now, this is sort of the interesting part. So when they were looking at lupus nephritis, basically what they found was that admixture accounted for about 36% of the variance. So what that means is that admixture, their genetic admixture, was responsible for about 36.8% of the difference between groups and their ability, the difference between racial groups and their ability to develop lupus nephritis. So there was a large percentage of things that were unexplained, 45.9%, and part of it was explained by person's socioeconomic status. When they looked at end-stage renal disease, again, similar numbers, but admixture only accounted for about 24.1% of the difference seen between racial groups. So, again, just to highlight that this study shows how ethnicity, it serves as a decent representative for genetic ancestry. However, there are definitely other factors at play that should not be ignored when we're looking at racial disparities. The next outcome that we were interested in was damage. And before I go into damage, I'll just show you this survey. It's called the Systemic Lupus International Collaborating Clinics Damage Index, or SDI. And if you're followed at the Toronto Western Clinic, you'll see us walking around with binders, and usually we're filling out, this is one of the surveys that we're filling out. And basically it gives us an ability to kind of monitor and sort of record how much damage is being done to an organ in a patient. And so we use that for research purposes. And so all of these studies use the SDI score, the damage score. And so again, with the Lumina cohort, against a very popular study with lots of research outcomes, this one study that was in 2004 identified that ethnicity was not predictive of damage accrual or the development of damage. Other factors that were predictive was disease activity, age, and steroids. Another study that was published in 2019 by the same group with the same patients, just or similar patients, probably overlapping, but a larger amount. Essentially what they found was that being Caucasian, African-American, Hispanic, Texan, compared to being Hispanic Puerto Rican, predicted damage. So those first 3 groups were associated with damage. So more about damage. There was another study among 617 patients, and they showed that at baseline, so at the initial assessments, African Americans had higher damage scores or more damage compared to the other three groups. However, at follow-up period, Tex and Hispanics had similar numbers to African Americans. So they both increased, but the Tex and Hispanics increased at a faster rate than the African American. And the other two groups, the Caucasian group and the Puerto Rican group, their damage scores remained quite low. Increased, but lower. And then the final study that I'll emphasize with damage was among 490 lupus patients, and they did not show any difference between damage scores between Caucasian and Latin American mestizos. So as you can see, there's mixed findings in the literature, some leaning towards there being differences, others leaning towards there being no differences. And of course, every study has a different design. The next thing we're going to look at is cardiovascular events, so heart attack and stroke. So this is another study that looked at a large database in the United States, had about 65,000 patients over a course of 10 years. And what they found was that Black patients had the highest rate of a composite score that looked at stroke and MI or heart attack compared to white patients in the cohort. And then they also found that Black patients and Hispanic patients had higher rates of stroke. They did not find a difference in the rates of heart attack among Black patients and American Indian Alaska Native patients compared to whites. However, Hispanic and Asian ethnicity was protective, meaning they were less likely to develop heart attacks compared to the white patients, which was the reference group. Another study that's had very similar results was done in the Hopkins lupus cohort from 1987 to 2011. And basically what they found was that African-American patients were more likely to develop stroke, but there was no difference in heart attacks, so similar to the other study. And then overall, ethnicity was not associated with higher risk of heart attack or stroke. The interesting thing about this study that I'll highlight is that they looked at other factors. So they looked at income, and what you can see here, this top one that I've highlighted in red just shows the damage scores per income level, and you can see that those with an income below 25,000 had an increased risk of stroke, and the higher your income, the lower your risk of stroke. So again, that really highlights the importance of looking at other factors that are sort of, peripherally related to race and ethnicity. And we see the same thing when we look at African Americans when we're looking at heart attack and stroke in this particular study. The next study that we'll highlight, or the next outcome, is related to malignancy or cancers. We only found a few studies that actually explored this, and they didn't delve too much deeper. But this one is the California statewide patient discharge data from 1991 to 2002, and they had various outcomes among racial and ethnic groups. However, overall, white patients had the highest proportion of cancer among all racial groups. What I've highlighted in red here are the different incidence rates among each of the groups. And you'll see in breast cancer, white patients, Hispanic patients had the highest standardized incident rates. When it came to renal cancers or kidney cancers, it was Black patients and Hispanic patients. And then when it came to vaginal or vulvar cancers, there was high levels in all of the groups. And then the final outcome that we'll look at is hospitalization. So I'll just highlight a few studies, the main findings there. This one study looked at 30-day readmission rates in lupus patients, and they found them to be higher in Black patients compared to white patients. The interesting thing about this study is they also looked at other factors. So they found that there was higher rates of readmission among those with worse area deprivation index, and the area deprivation index essentially reflects your resources. So really they're looking at, what community do you come from, and on what scale of poverty to wealth does that community rank. And so the higher your area deprivation index means you come from a more deprived community. So that impacted outcomes as well. So again, we're finding peripheral factors that might sort of link to race if you get into the whole history of things. But these are things that we always have to keep in mind when we're looking at racial disparities. This next study looked at or found that Latin American mestizos had higher frequency of hospital admissions compared to European Caucasians in the study. However, there was no difference in morbidity or mortality, like death rates, attributed to lupus, regardless of their more frequent hospital admissions. And then this last study here of a national sample of inpatients over the course of 3 years found that Black women were the youngest to be admitted with cardiovascular disease, so heart attack or just heart attack, compared to whites, Hispanics, Asians, and other race and ethnicities. So just to summarize, we've sort of provided a comprehensive review that highlights the higher reported rates of various outcomes that we looked at. So namely mortality, end-stage renal disease, disease-related damage, cardiovascular disease, hospitalization, and malignancy. And we can see that there is some variability in the studies, but overall the trend was, as we had suspected going in, that racial and ethnic minorities with lupus tended to have worse overall outcomes. And again, back to this diagram, really what we need to understand is that, genetic ancestry likely has a role for sure, but that it doesn't completely account for these differences. So when we're actually trying to assess these racial disparities that we've identified, we need to use targeted interventions to address socioeconomic status, if we can, sort of environmental factors, and even access issues that might be contributing to these disparities. And in doing that, we hope to minimize disparities as much as possible. Now, if you'll notice, a lot of the literature that I highlighted was American literature, because that's what we found. However, what do we know about racial disparities in lupus in Canada? So I'll highlight 2 studies, lots of big names there that I'm sure you've seen present in the past. This one is called Ethnic Variation in Disease Patterns and Health Outcomes in Lupus. And the objective of this study was to investigate the association of renal disease and damage, CNS or brain disease and damage, overall end organ damage, so any damage in any of the organs, and mortality or death to ethnicity. So basically they were just trying to see, is ethnicity associated with the development of these outcomes. And so here I've just highlighted a few things. You'll see on this table here that's summarizing the different characteristics of the patients, that there are differences in age, duration of disease, like since they've been diagnosed with lupus, and their follow-up. What you'll notice here is that Chinese Canadian patients were the youngest at diagnosis. Caucasian patients have been followed the longest in this cohort at the clinic, and this is actually from Toronto Western Hospital Clinic. And Caucasian patients also had the longest disease duration. You'll also note here that African Canadians were more likely to have high blood pressure and diabetes, which we know is related to some of the outcomes we see in lupus, such as stroke, heart attack, or even kidney disease. And then there were no differences in treatment between groups. So you'll see I didn't highlight that any of the treatments there, meaning essentially all groups were requiring the same amount of same types of medications to some capacity in this study. The main finding I'd just like to highlight here is that we do see higher damage in the kidneys in patients in the Chinese Canadian population and African Canadians compared to Caucasian Canadians in this study. Again, we know that high blood pressure and diabetes can cause kidney disease regardless of whether or not you have lupus. So they did do some calculations to make sure that wasn't impacting things, and they still found that there was an association with being African Canadian and Chinese Canadian and developing kidney damage. The one thing here that differs from the American studies, or the largely American studies, is that they didn't see any difference with mortality. So if you remember from the American studies, there was quite stark differences. But as you can see here, there's essentially no difference between these 3 groups. So what this figure shows here is this line here reflects the deaths. So the lower the line, the lower that the line gets, the more deaths that are happening in that population over time, over 5, 10, 15, 20 years. And you can see they kind of go down around the same amount of time. And so there's no significant differences in this cohort or that population. A second Canadian study that I'll highlight is the 1,000 Canadian Faces of Lupus, Determinants of Disease Outcome in a Large Multi-Ethnic Cohort. Again, a lot of major Canadian researchers did this study. And what you'll see here is there's about 1,416 patients, mostly Caucasian. And Asian patients in the study were less likely to accumulate damage compared to the other groups. Even their damage scores, so that survey I showed you, were lowest compared to the other groups. However, race and ethnicity overall did not independently predict damage. So similar to some of the studies that we saw, some of the American studies, race and ethnicity in this patient population wasn't associated with damage. I just also wanted to show here in this study, unlike the other Canadian study, there were differences in treatment requirements. So when it came to prednisone, Asians and Afro-Caribbeans were more likely to require prednisone up front and then also have a history. When it came to cyclophosphamide, Aboriginal, Afro-Caribbean, and Asians were more likely to have a history of using cyclophosphamide. Afro-Caribbean and Asians were more likely to be on mycophenolate at their baseline visit and in the past. And then azathioprine was more commonly used in Aboriginal and Asian patients, or at least reported as used in the past. And then methotrexate was more commonly used or reported as previously being used by Caucasian patients in this study. Okay, so what accounts for some of these differences that we might be seeing? I know there's not a lot of Canadian studies, but hopefully we'll get some more over the next few years. But when we think about differences between at least Canada and the United States, it leads us to wonder, could this be related to healthcare system differences, as was postulated in some of the studies, the last two studies that I just mentioned? Could it be related to differences in socioeconomic status, so education, income between different groups, or could there be other factors kind of along this pie chart, or even outside of the pie chart, that are contributing to some of these differences? And so this definitely needs to be further explored, specifically in the Canadian context, because maybe the data that we're seeing that's largely coming from the US or other parts of the world isn't generalizable to Canada. So that's what I'm seeking to do with my tenure as a Jeff Carr Fellow. I would like to look further at racial disparities in Canada and see if we could, identify whether disparities exist, and if they do exist, why do they exist, so we can intervene and do what needs to be done in our setting. And so we'll be doing several studies, but overall our aim is to identify the impact of race and ethnicity on disease trajectory among a Canadian cohort of lupus patients. So we're talking about disease trajectory, we're talking about their disease activity over time and disease related damage over time. And really what we want to do is assess whether there are disparities in disease activity and disease related damage among Canadian patients first. So we just need to reestablish whether that's still the case. We also need to determine the impact of race and ethnicity on disease activity and the impact of race and ethnicity on the development of disease related damage over time. And so we will do that first. And then what we also want to do, because if you notice those older studies, there was no comparison to other cohorts or other study populations outside the country. So part of our research objectives or our analysis is we're going to look at data from another cohort or a group of patients that includes international data. So it's called the SLE cohort. You may have heard of it. And so that will allow us to kind of see, are there differences that exist in both groups, or are there discrepancies between the groups? And if so, then we can start thinking about, okay, what's different about having lupus and being treated for lupus in Canada, and how can we address disparities to make sure that we're really providing focused intervention. So just one thing I'll highlight here, remember how I had said race is social construct and the definitions can be different in different parts of the world, and we saw that in the studies. The Canadian Institute of Health Information recently recommended certain categories to be used to standardize at least the racial terms. And so we are currently trying to integrate this in our protocol so that we can include that in our study and then at least be consistent with other studies that are being conducted across the country. So again, this is what I hope to do, and hopefully I can come speak to you guys at another time and update you with what we found to provide you with some more information to address some of those questions of what's different in Canada. And so, why is this research significant? Well, hopefully by identifying health disparities, we can improve quality of care, and we can use this information to inform the way that people practice, or rheumatologists practice, policies, and future research. And I won't go into this diagram too much, but I just wanted to highlight here that, once we identify that there's disparities, if they exist here, these are some of the areas that we might be able to sort of do intervention on. So, if there's access issues, if there's issues with treatment, so, self-management issues, or even just obtaining medications, social support or health-related behaviors, these are what the interventions will look like, along with, policy and things that are a little bit higher level. So hopefully I've addressed all of the objectives, and I hope that at the end of this presentation, you can define health disparities, race, and ethnicity. I've tried to give you a good review of racial and ethnic disparities in adult patients with lupus. And we've had a discussion about what is known about racial disparities in lupus in the Canadian context, and highlighted that we do need to do some further research, which I will be doing over the course of the next few years. So in summary, race and ethnicity are social constructs. So that's what you take away from this. Just keep that in mind. However, just because there's no biologic basis doesn't mean they're not important. So we still need to look at them. Racial disparities in lupus are related to an interplay between genetic and non-genetic factors. So we always have to think about those non-genetic factors and how we can intervene on those to reduce disparities. And then racial disparities in lupus outcomes are well known, but should further be explored in the Canadian context. Here are some of my references, and that's it. I will stop sharing.
Thank you very much. That was an incredible presentation and a lot of information. Certainly gives a different perspective on how to look at race and ethnicity, and I'm sure a lot of us never really considered that those terms are really just a construct of society and not necessarily a term that has a direct impact specifically on somebody's health journey as they live it organically. It changes obviously when they interact with the system, but that's a really interesting perspective. We do have a few questions in the chat, and I think I have a couple of my own too. So we'll start with the questions in the chat, and I can kind of read them off to you if you'd like. So we have a first one speaking about treatments, and specifically response to benlysta and rituximab in Asian populations, in Asian patients with lupus. If you have any information or kind of commentary on those treatments in that population.
Yeah, so I think the person is asking, are there differences in response to benlysta and rituximab among Asian patients? I didn't come across that in my literature, and I'm not aware of any differences clinically. Sometimes we see differences, or at least in practice, you'll hear people differentially prescribe things like mycophenolate versus cyclophosphamide in certain patient populations. And this is because of different research studies that found that maybe there is a better response in one patient population versus the other, not particularly Asian patients in this circumstance. However, that's the only thing I can really think of. I just think that when we do make different treatment decisions based off race and ethnicity, we always should keep in mind that there's no biologic basis to race. There is genetic ancestry, and genetic admixture, which we kind of found, race and ethnicity can kind of be a proxy to. But if we're gonna make treatment decisions based off race and ethnicity, we should really be sure that there is a biologic basis for those decisions, because we wouldn't want to give one group a medication versus another group of medication, and they have different outcomes because we're treating them differently. So that's always something I'm kind of keeping in mind whenever I see those different practice patterns or research studies.
And next question, are there any ethnic disparities in immune screen testing or preference regarding medication choice or treatment plans?
Yeah, so I did comment on the medication choice or treatment plans. In terms of immune screen testing, the one study, I think it was the second Canadian study, I believe that they did look at different markers. So, sometimes we test an ANA, you'll hear us send tests like antiphospholipid antibodies. And I can't remember off the top of my head, but I know that antiphospholipid antibodies were higher among, I think, Indigenous patients in that study. There were some difference in some of the ANA antibodies as well. And so that's informative. I mean, we do test all our patients for all these things, but it's just something, for us to keep in mind, because if someone has positive antiphospholipid antibodies, it doesn't mean that they actually have that syndrome, but it's something that maybe, we're kind of keeping at the back of our minds to look out for. The one thing I will comment, I'll try not to talk too much, is that we also have to be careful with blood tests and things like that. Recently, over the last 2 years, we've made a huge change in the way that we across the world, that we actually assess kidney tests. So like your creatinine and your EGFR, they used to have this correction where they would say Black patients essentially could have slightly worse renal function based off those tests, because there was some theory that it had to do with muscle mass, etc. And again, there was no evidence that there was a biologic difference between racial groups. And so this has recently been recanted, and we no longer use those classifications. So if we're going to be doing these things, we need to make sure that there's sound science between making those decisions.
Just kind of diving into that one a little bit more in detail just before we move to the next question. How big of a problem is that for you when you're looking at these different studies from different areas of the world? You have people who have different definitions of categories of diseases, or they have these kind of corrective factors in place that they think should be there. How does that impact what you're trying to do to really understand the disparities, and how do you kind of work to account for that? You just mentioned a little bit of it, but I'm just wondering if we can dive a little deeper on that one.
Yeah, and I think that's the challenge with research in general, being conducted in different parts of the world, that you have to consider the context, like you said, and how things are interpreted. That's why we did a systematic review, because it just gives us a high level overview of different trends. And then it kind of allows us to narrow things down to our context. So now that we've done this systematic review, I have a broad idea of what things might look like. And then it's important to do studies within your context. That's why we're doing it in Canada, to see, not just assume that things are as they were in the previous studies, but to really say, okay, is this what we're seeing here? And if that's the case, why are we seeing it here? And if that's the case, how do we address it here? So that's why it's very important to have researchers all across the world asking the same questions and addressing it in their patient population.
And then back to the chat for a moment, the Q&A. There's a couple that I'll link them together, I think, in combination a little bit. So the first one is talking specifically about, is there any difference in sun exposure as a risk factor in ethnicity? And then second one goes toward, is there a variation in B cell activity to treat or not with B cell depletion therapy? I know they're not directly related, but I'm going to lump them together.
Yeah, no problem. The first study, I mean, I didn't come across it in our literature review. I mean, you would think perhaps, darker skin, the less absorption of the sun, et cetera, et cetera. But I did not come across that in my review. Our recommendations are that every lupus patient practices, reduces their exposure to sun, where sunscreen, et cetera, sun avoidance. So I think that should be standard regardless. Perhaps we did miss, if there are differences, perhaps we missed it, because again, the criteria to be included in our review is that you have to be followed for 2 years. So there might be something that I missed, but again, I don't think it should change our recommendations. Again, I didn't find anything in our studies regarding B cell activity, whether or not to treat with B cell depletion therapy. Like I said, the only time in practice that I see people treating different ethnic groups differently would be with mycophenolate versus cyclophosphamide, based on previous studies.
Okay, and maybe more so a commentary on if you could offer maybe on some of the topics in the presentation. So it's we all know that lupus is known as a disease of 1,000 faces. No one has the same journey. The symptom onset can be very different from patient to patient. It seems like that's also reflected a little bit in the reviews that you've done. So you had, for example, a 30-day readmission rate that was higher for Black individuals compared to whites, especially in a deprivation area. But then again, if you looked at information from Latin America, there wasn't necessarily an association between increased morbidity and mortality attributable to hospital readmissions. So I wonder if you could just comment on that a little bit more. So how hard does that make it to kind of figure out to what degree ethnicity plays a role in lupus?
Yeah, it's really challenging because there's so many different factors, right? You want to jump and say, oh, it has to do because there's genetic differences or differences between races, so they must have worse disease, therefore they must be admitted. Like we want to jump and say that. Maybe that's the case, that their genetic admixture puts them at increased risk. But we just need to do more research, at least in the Canadian context. And so I didn't go into a lot of detail because I'm working with Dr. Zahi Tuma and Dr. Sindhu Johnson on the studies that I'll be conducting over the next 2 years. And we're still defining our questions, but we have the very same sort of questions, like how do we sort this out? And so we will be looking at various different measures to determine, if there are differences in race, are there, differences in the way that their disease looks over time, progresses over time, damage adds up, and then hopefully by doing it in our context, we eliminate some of the factors. Like in the other studies, the most obvious factor would be healthcare access. In the United States, we know it's not universal. In South America, not universal. So, we're hoping that within our context, we can kind of figure out as best as possible what it looks like in our patient population, and also by comparing it to that second cohort, the SLE cohort, which is an international cohort, that might help us sort these things out differently. But it's really challenging because every single person's different, like you said, their disease is different, and there's just so many different factors. But we'll do our best to kind of see what we can figure out so that we can help as many people as possible.
Perfect. Well, we look forward to having you back with us again to hopefully dive into more details on this. Thank you so much for your time this morning. I hope everyone enjoyed it and you as well. So thank you very much. And we are now going to move to the Barriers to Care presentation with Dr. Celios. So everyone will be transitioning there momentarily. Thank you, everyone.